All right, everyone. Thanks for jumping on today. Very lucky to have Associate Professor Michael Robertson here to talk to us today about psychotropic drug use in people living with disabilities. So I'll let Michael talk a little bit more about his background, but Michael is the Chief Psychiatrist for the Med Health Group and is an absolute wealth of knowledge in this space. And it's an area that my team here in Victoria in particular wanted to get some more guidance on and some understanding. So I'm really looking forward to hearing what Michael is going to discuss with today. Michael's already indicated at any stage, guys, if there are questions, just use the online emojis and raise the hands. Please interject at any stage to ask questions, seek clarity, or chuck any questions that you may have into the chat, and I will facilitate that chat while Michael's impressing his vast wealth of knowledge onto us. So I'll hand over to you now, Michael.
Thank you, Chris. Good morning, everybody. Apologies in advance. I sort of day 7 of this sort of lurgy that's been inhabiting everybody's lives. So if there's a bit of coughing through the conversation, at least you won't catch it. So I'd like to talk a little around the topic of psychotropic drug use in people living with disabilities, and in particular just to highlight some of the broader ethical and clinical implications, and then talk specifically about the different types of medications you might see used in your clients and what you want to be mindful of when you're working with them. So let's want to foreground where the NDIA stands on this, because I think certainly the aftermath of the Royal Commission and a lot of the other inquiries that have been conducted after the first decade of the NDIS have identified there are some problems. So just to remind us that under the Act, the use of medication or chemical substance for the primary purpose of influencing a person's behaviour is a chemical restraint. It's a restrictive practice. And unless the medication is prescribed by a medical practitioner for the treatment of or to enable treatment of a diagnosed mental disorder, a physical illness or physical condition. I think that's something of a false dichotomy because I think most of the behavioural disturbances that we might see being indications for psychotropic medication relate to an underlying psychological disturbance, whether it be anxiety, depression, or some sort of other condition. So it's rather than using a medication just to quieten something down or to target a behaviour. In most circumstances, there is usually an underlying process that is in some way being mitigated by this. But just to be mindful of, think of this idea: are we treating a behaviour, or are we treating a person's distress? And really, can you make that distinction? The joint statement from the Australian Commission on Safety and Quality Healthcare and the NDIS Safeguards Commission found, I'll just direct you to the bottom of this document, that they had concerns both in the aged care and disability care space, which I think are analogous circumstances, given vulnerabilities of the people that we are providing care for. Firstly, that psychotropic medications are being overprescribed and overused, particularly with older people and people with disability. Now, that literature probably dates from the 1990s. There's the original investigations into the use of psychotropic medications in aged care facilities, usually to mitigate behaviour disturbance. There was concerns around the use particularly of antipsychotic medications and the risk of stroke and other medical complications, which I'll talk to a bit later. The second point identified by the group was that there's little evidence that the actual medications are that helpful, and often there is a circumstance of, for want of a better metaphor, stepping on a rake. You try and solve one problem with a psychotropic medication and create a whole lot of other problems through side effects or unintended consequences. The evidence that psychotropic medications contribute to the risk of harm for older people and people with disability, and I will speak a lot about that towards the end of the talk, and that is in particular issues around falls, weight gain, hypertension, metabolic ill health, which we see particularly with antipsychotic medications. But also, if we are dealing with people with significant medical comorbidity as well as their, say, intellectual disability, you are increasing the risk of a whole lot of other problems by if you're reducing people's mobility or they're spending a lot of time in bed, they're going to get complications from what they call hypostatic risk, which, risk of deep venous thrombosis, pneumonia, and all the other kinds of things that we see. So there has been, considerable concern about you can quieten people down too much, and it actually has a deleterious effect on their physical health. And also, I think the reason we were doing this is that if we are doing something that diminishes the well-being and quality of life, particularly of older people, but I think also people living with intellectual disabilities that we care for, we've got to ask the question, why are we doing what we're doing? Are we putting them out of, are we sort of making life better for us or making life better for them? So I think those are some pretty confronting propositions, but I think they are really the foundational questions we've got to ask when we use these different types of medication. Now, I think one of the thought leaders in this space is Julian Troller, who I trained with many years back at the University of New South Wales. And Julian's sort of wrote a very nice article here. It's about 10 years old now, but the principles still obtain. And his observation was that the inappropriate use of psychotropics is common. The overuse of psychotropic drugs to treat challenging behaviour, excessive dosages, and the duration of treatment, and polypharmacy, which is multiple drugs used at once. And there is often inadequate monitoring of these adverse effects. So these are, again, the same question, the same challenges that, what are we doing? Are we doing it too much? Are we mixing things up too much? Are we losing sight? Are there too many prescribers? The whole thing really becomes a bit of a hot mess that will have negative effects for the client and create a whole lot of problems that would not have existed if not for these at times misguided interventions. So I might just pause. Has anybody got any kind of reflections at this point or any kind of observations before we move into the particular medication classes? And Chris, I don't know if we just people shout out or they...
This group's pretty comfortable shouting out, I reckon, if there's something there.
All right. So that'll come through as a voice or if
they'll chuck up an emoji hand up, or
all right,
they'll just start screaming out at us, Michael, and we'll know that they're ready.
Scream away. All right. So just to, I think, just have this diagram in mind. The rationale for using psychotropic drugs for people living with disabilities, there is this balance between symptom relief and behaviour modification. Now, I'm not saying that we should never look at behaviour modification as a consideration in the choice to use psychotropic medication, but it should not be the only motivation or the only indication, particularly where the behaviour under concern may arise from other factors that are amenable through environmental change or the change in the way we create the care circumstances for the person. So I'm not saying behaviour modification has to be completely binned as an indication, but it needs to be very much a second or third order consideration. The primary rationale for using these drugs is relief of symptoms, whether it's symptoms of anxiety, symptoms of agitation due to chronic pain or some sort of physical issue. These are the sorts of questions we've got to ask. So it needs to be the end result of a very deliberate and consultative process by a medical practitioner seeking multiple views from the participant where we can, people tasked with the care of the client, the family, and other caregivers to say, well, what are we doing? What are we actually treating? How are we going to monitor treatment response? How are we going to monitor adverse effects? All right. Now, the first group of drugs we will see, particularly in younger participants, the stimulant medications. I've used the trade names just for this particular class because some of the other drugs have got multiple trade names and the slide gets too busy. It's always important to use generic rather than trade anyway, so we know that we're talking about. So the main stimulant medications used predominantly for the management of ADHD, which is a frequent comorbid condition, particularly with intellectual disability. Methylphenidate or Ritalin, which has been around for years. Dexamphetamine, also almost as old as I am. The newer drug Vyvanse, lisdexamphetamine, which is a metabolite of dexamphetamine. And at one point, there was actually a worldwide shortage of Vyvanse because, for reasons that are still unclear to me, there is this burgeoning industry of ADHD diagnoses being offered by clinics. So, lots of people are off trying to get an ADHD diagnosis in adulthood. There are some people that do live with ADHD in adulthood. The vast majority of other attentional difficulties relate to problems not to do with ADHD, but that is a whole other conversation. And we also see atomoxetine, which is a non-amphetamine stimulant. Ultimately, what these drugs do is they boost availability of dopamine, which is a very important neurotransmitter that helps to function with concentration and attention in the frontal cortex. So by taking stimulant medication, in fact, if you went out and scored yourself some crystal methamphetamine, what you'd be doing is you'd be giving yourself a dopamine bath, but basically these drugs do elevate dopamine, which helps to enhance cognitive function and also have some euphoria effects. So they can be drugs of abuse. So the usual indication, or the only indication really, should be ADHD. That said, certainly in North America and in I think in Europe, they do use these drugs as augmentation medications for antidepressants. It's not something that we routinely do here. It's usually in younger patients or younger clients, so adolescents and perhaps some young adults. And the main concerns we have about stimulant medications are firstly, particularly with the younger patients, is appetite suppression leading to slowing their growth. So when a kid is taking a stimulant medication for ADHD, the usual monitoring is having them hop on the scales and measuring their height, because if you're giving them medications to stop them eating, they're not going to get the necessary calories to grow. Now, for some at my age, 'tis a consummation devoutly to be wished, but certainly with younger people, it's a problem. Like any stimulant, they're going to cause sleep disturbance or agitation. And over time, we've seen the emergence of tics, which are involuntary neurological movements. They're usually the concurrent what's the word? It's basically you get antagonizing muscle groups activating together. So like that's a tic, and that's usually the agonist and antagonist muscles are activating together, causing this sort of twitchy thing, and they can be quite disabling. We've also seen some circumstances where patients taking stimulant medications, because they're boosting dopamine, well, they'll suffer psychotic symptoms. So we have seen some cases of medication-induced psychosis or the unmasking of an underlying psychotic or severe mood disorder, such as bipolar disorder, from the use of these medications. So I think in this population, I think, again, we see these used because ADHD is seen as quite a common comorbidity with other I suppose, conditions that lead to learning difficulties, but they are drugs to be aware of, particularly with younger patients. Now, the other group that we see used across the board are sedation, and this is there are a couple of different classes of medication that are used for nighttime sedation, particularly in younger folks. So melatonin, which is ostensibly a naturally occurring sedative. Your pineal gland secretes melatonin, which helps induce sleep. And in fact, one of the hacks if you're having trouble getting off to sleep, a useful hack is to either if you can get a sauna, or have a warm shower or a warm bath, because the heat shock induces release of melatonin and can actually induce sleep. Agomelatine is it's marketed as antidepressant medication, but I think it is an expensive sleeping tablet. I've not really been that impressed with agomelatine as its antidepressant use. And then we get some of the old sort of HX Holden model sedation from clonidine, which has having a little bit of a revival because it's being used in post-traumatic stress disorder for treatment of nightmares and flashbacks. But for many years, clonidine was the go-to medication, particularly for young kids with ADHD who were constantly on the go at night. But it is used in some circumstances in other settings. Clonidine was originally a antihypertensive medication, and so the main side effect of clonidine to be aware of is low blood pressure. And then we have the benzodiazepines, which are medications like Valium, Xanax, Mogadon, and the like. Now, those drugs are really to be avoided, particularly in this patient population. For the first reason is that, as the NDIS reported, that it's associated with risk of falls, and that's for older patients that can be a pre-mortal event. Often people will go into hospital with a fractured hip and not come out, so we want to avoid that where we can. They can affect cognitive function, and that's obviously of concern. They also, in some circumstances, can have what they call a paradoxical effect. So, in fact, you might, give somebody a benzodiazepine to quell their agitation, and in fact, it has the opposite effect of aggravating them further through disinhibition. But the big challenge with the benzodiazepines is their dependency potential. So for many years when I was a medical student back in the 80s, you would have a lot of older patients prescribed, Normocin or temazepam or something, and they'd take it for 15, 20 years, just thinking it was just a fairly innocent thing to do. Then they would go into hospital with some unrelated problem. The medication wouldn't be charted, and they'd end up in quite a problematic benzodiazepine withdrawal. So there was for a while a lot of people out there living with subacute benzodiazepine dependencies because of the well-intentioned but ultimately misguided use of these drugs. So I think if we've got a patient, if we've got a client on a benzodiazepine, you probably need to ask why this is being used long term, because the drugs are extremely problematic. Probably the most, I think the safest of this class would be the melatonin. And it's a bit hit and miss. Some patients, they'll be out like a light. Others, you might as well stick it up your nose. There's no predicting that. But I think, again, this particular space of psychotropic use is problematic because, again, the question's going to be asked, well, why is sedation required? Why is the person not sleeping? What are potential environmental changes we can make? And as I say, perhaps encouraging the client to have some sort of heat event prior to going to bed, whether it's a warm bath or a warm shower or something like that. That may actually help mitigate the need for a nighttime sedation. Okay. I'm assuming silence means everyone's getting this. All right, so now we get to the antidepressants, and this is where it gets, there's a lot going on, and to put everything on a slide would just make it too hard to follow. So medications that we are seeing most frequently used are the SSRIs. So those are the selective serotonin reuptake inhibitors. These drugs inhibit the reuptake of serotonin, which is a neurochemical very important to mood. The medications that are used out most commonly are fluoxetine, and that's the antidepressant of choice for younger people. It's got the best safety profile. So fluoxetine, Prozac, Zactin, Lovan are some of the names you might recognise. Sertraline is usually marketed as Zoloft, but Axit is another trade name. Escitalopram usually is marketed as Lexapro, but there are some other trade names. Paroxetine is Arapax. We tend to not use that too much now because paroxetine's got a really bad withdrawal syndrome associated with it. And more recently, vortioxetine, which appeared probably 3 or 4 years back. Very, very powerful antidepressant. The problem is it causes profound nausea. So a lot of patients are too busy vomiting to be depressed. So I think what we'll see, you'd probably see people on, I would say probably escitalopram is probably the most commonly prescribed SSRI at this point. So they're used for the management of depression. They can also be used for the management of anxiety, such as panic disorder or generalized anxiety. They're also used for obsessive compulsive disorder, except the doses needed for OCD are much higher than the doses we need to use for depression or anxiety. But they're also used for some other, what they call OCD spectrum disorders. So in fact, tics, things like, oh, brain's not working, tic disorders, such as Tourette's, in some way linked genetically and possibly symptomatically with OCD. So some of those conditions do respond quite well to SSRI, as do body dysmorphic disorders. The second class of antidepressants we see used more prescribed by psychiatrists than by GPs are the SNRIs, or the serotonin noradrenaline reuptake inhibitors. These are dual action antidepressants. They block the reuptake of serotonin and noradrenaline, another really important chemical we think for depression. The two most commonly used would be desvenlafaxine or Pristiq. Its earlier manifestation was venlafaxine, which was known as Effexor. What desvenlafaxine is basically the primary metabolite of venlafaxine. So if you took venlafaxine, it's absorbed from your gut, it passes through your liver turns it into desvenlafaxine, which is actually the active component. The reason the drug company started marketing desvenlafaxine was a process called evergreening, which basically means the patent ran out on venlafaxine, so they decided to prolong the patent and their ability to charge more by manufacturing the primary metabolite, basically taking the liver out of the question. But it's the same drug, it's just been rebadged. The other SNRI is duloxetine, or Cymbalta, which sounds like an Indian dish, but it's been around for a while. Cymbalta is used both as an antidepressant, but increasingly it's being used for neuropathic pain. So you see a lot of Cymbalta thrown around in pain clinics. The noradrenaline, serotonin, NASA class medication, the best known that is mirtazapine or Avanza. That's a very sedating antidepressant medication. It's often used where sleep disturbance is a big challenge. Often you see mirtazapine combined with another antidepressant, and increasingly what we're seeing, it's a bit like antihypertensives or blood pressure medication. Most people with blood pressure end up having to take 2 or 3 different blood pressure medications in combination. That's not because their illness is any worse or because of anything to do with the patient. It just happens to be that the combination of different antihypertensives seems to work better than any single one. And the same seems to be the case with antidepressants. Mirtazapine gets thrown around a lot in prisons. I see a lot of historical abuse claims, and many of them are in jail, and almost all of them are on mirtazes, as they say, because they want to sleep. Some of them aren't actually that depressed or that anxious, despite being in jail, but they just want a night's sleep, so they go and get mirtazapine from the MO that way. I would be really concerned about someone having to take mirtazapine long term for sedation, in the same way I'd be concerned about someone taking benzodiazepine for sedation for the same sort of reasons. Melatonergic, agomelatine, I think that's expensive placebo. That said, there's a 90% placebo effect for antidepressants, meaning if you give 10 people with depression, how does it work? So basically you take 9 out of 10 people taking antidepressants would get the same benefit from the sugar pill. Make of that what you will, but I think agomelatine really is just an expensive sedative, and I don't think it's really going to be that much of a commercial success. Now, the big thing about antidepressants is particularly SSRIs or the side effects. The most complained about side effect profile for the SSRIs is actually sexual dysfunction. People with taking SSRIs will describe significant reduced libido or may experience some difficulties with orgasm. Others get agitation, sleep disturbance, sweatiness, those sorts of things. So they're usually prescribed in the morning because of the sleep disturbance associated with them. Some of these medications, particularly paroxetine, can have quite unpleasant discontinuation effects. So if for some reason, a script isn't filled in time, like a Friday night and I've run out of my sertraline, by Monday, the person might be quite agitated because they're going through an SSRI withdrawal syndrome. So we need to be aware of that. And also when these medications are stopped, they need to be stopped extremely slowly over 6 to 8 weeks, because you can get very much a rebound hyper emotional state with them. So, we've had SSRIs since the 90s. I think we've probably seen the worst of their side effects, but I think the jury is still out as to what ultimately these drugs do. In my experience, the really severe depressions don't tend to respond as well to the SSRIs as they do to the SNRIs. I haven't mentioned the tricyclic antidepressants, which are an older class of medication. We don't see them used that much outside of specialist clinics, but those would be medications like prothidin, NDEP, which again we see more used for chronic pain than we do for depression or anxiety. So, I mean, those have lots of side effects, but I would be concerned about a tricyclic antidepressant being used in this population unless it was a specialist prescribing it and a specialist monitoring the clinical response to it. And then we have the antipsychotic medications, and this is probably where most of our concerns should be situated. So these would be the most commonly used medications for mitigating behaviour disturbance. So, for example, people living with autism who demonstrate problems with aggression or intense distress will often be prescribed an antipsychotic medication. Younger people in particular get prescribed risperidone or quetiapine. So risperidone is known as Risperdal, quetiapine is Seroquel, and there are some other trade names for that. So when I started training in the 1990s, we basically just had the first generation antipsychotic medications. So we had the old Largactil or chlorpromazine, there was flupentixol, which was an injection used for people with schizophrenia, haloperidol or Haldol as was known, and trifluoperazine or stelazine. Now, I can't remember the last time I saw a person taking these medications. I left the public system in 2013, so yes, there were still people on flupentixol injections, but outside of that clinical practice, I haven't seen anybody taking the old first-generation antipsychotics for quite some time. In contrast to second-generation antipsychotics, so we have olanzapine or Zyprexa, Risperdal, paliperidone, which is known as Invega, which is taken either as a tablet or an injection, quetiapine, which is Seroquel, which is used quite a lot for sedation or for agitation. Azenapine or Sapphirus, which really only gets used either in schizophrenic illnesses or bipolar disorder. And then you've got aripiprazole and brexpiprazole, which I have seen used in a mood disorder setting outside, and obviously they're used for antipsychotic for schizophrenia and bipolar, but can't think of anyone I've seen, say, with autism or any other kind of condition leading to intellectual disability that are being treated with aripiprazole or brexpiprazole. Now, these tablets are usually given by mouth, but there are some circumstances where they're given by intramuscular injection. It's usually a long-acting injection, which is such once a fortnight to once a month. So you'll see like Risperdal Consta, which is like a fortnightly injection, Invega Susteno, I think it's called, which is like a monthly injection. And I think aripiprazole is also available in a long-acting injection as well. But again, I think if we've got any of our sort of clients, NDIS participants on an injection unless they are living with a severe and persistent mental illness. I think we'd have to ask, why is this person getting injectable antipsychotics? What's the consent structure here? Who's overseeing it? Now, the first generation antipsychotics, their big problem were the neurological side effects, and akathisia, or akathisia as it's known, is a Greek word. It, I think, translates to full of dirt, and basically it's a extremely unpleasant motor restlessness. If you see a patient with akathisia, they're quite agitated. They're often very motor restless, and we describe an internal sense of feeling just dreadful and agitated. An extremely problematic side effect, and is associated with elevated risk of violence, because people just feel so dreadful with that side effect that they often lash out. We see dystonia, which are kind of like, I suppose, really quite severe muscle spasms, often affecting large muscle groups. Can be quite unpleasant. And then one of the big dilemmas we had for many, many years in psychiatry with the use of these drugs is a condition called tardive dyskinesia, which was a late onset irreversible movement disorder, often manifested as orofacial movements that were involuntary, so like that. And often if you were working at some of those old back wards, like in Roselle Hospital or Cumberland and the like, you would see patients who'd been in hospital for 30 years on these medications demonstrating quite dramatic manifestations of that. Excuse me, Seabass. Picked the wrong week in this talk. Now, the big concern, I think the one takeaway from today is the problems related to the use of the second generation antipsychotic medications and their effects on physical health, particularly metabolic health. Patients taking medications like Seroquel or Zyprexa can gain up to 20 kilograms within a month of the medications. Most of the weight gain is done in the first 6 weeks is sustained in the first 6 weeks, and very hard to shift. I've also seen patients develop, overt type 2 diabetes because of these medications. I've seen their cholesterols, their bad cholesterols triple. And what we see is accelerated atherosclerotic cardiovascular disease. Now, if we think about the literature in here, the life expectancy of a person with schizophrenia currently is comparable to the life expectancy of someone born in 1901. And that is due to poorly managed physical health problems, many of which are caused by the treatments we impose. So, the common cause of death is accelerated atherosclerotic cardiovascular disease due to metabolic health and other lifestyle factors. I think we see similar data for people, particularly living with intellectual disability, where they are, I think, in many ways, an analogous population to people with severe and persistent mental illness due to the use of these medications. But I think more importantly, the significant social disadvantage faced by people living with disabilities, whether it be living in food deserts, as we see in North America, but I think increasingly here with the cost of living challenges, it is expensive to fill your supermarket trolley with fresh fruit and vegetables. It is easier and cheaper to eat highly processed, nutrient-deficient food that will kill you, not just through metabolic ill health, but by poisoning your gut biome and the like. So I think what's really important for this is to be mindful of the severe challenges that this group of people face to physical health through lifestyle-related causes that are as much to do with poverty and social disadvantage as they are with the medications that we treat them with. So I think, if nothing else from today, if we go about our business being mindful of the elevated risk of atherosclerotic cardiovascular disease, or rather the elevated risk of metabolic ill health and all of its consequences. If you were to think about the 4 horsemen of the aging apocalypse, the 4 conditions that everybody in this conversation will probably die of will be cancer, heart disease, metabolic disease, or neurodegenerative disease. All 4 of the, and I think, and also there's a correlation between poor metabolic health and depression. It's the 5th beetle. All 4 of those conditions have at their core insulin resistance. So cancer loves elevated blood sugar. Neurodegenerative conditions such as Alzheimer's disease, Parkinson's, and the like are associated with elevated blood sugar, not just diabetic levels, but just that insulin resistant levels. Obviously, type 2 diabetes is per excellence that condition, and also atherosclerotic cardiovascular disease, so ischemic heart disease, stroke, peripheral vascular disease, and the like. All of those things have at their core poor insulin functioning, and insulin resistance. Ultimately, yes, there are some genetic vulnerabilities in some circumstances, but for most of us, it relates to poor diet and inactivity. So I think, I've sort of made it my business as Chief Psych to try and promote intervention. So we've set up a treatment for depression program using exercise as the intervention. I'm sort of quite passionate about trying to disseminate that through the group, that we want to try and utilize our exercise physiologists on the team and utilize what we know about nutritional interventions to try and promote not just health and well-being, but actual prevention of metabolic illnesses. If we are dealing with people who are, on average going to die 20 years younger than their peers, a lot of that relates to metabolic ill health, which, I think is an imperative in our interventions. Okay, so I want to move to the take-homes, and then we'll throw open the conversation. Actually, there's a question there from Ryan.
Yes, hello. I'm happy to do your take-homes if you want to first.
No.
But I'm definitely keen to talk about that slide and some of the things that came from that.
Which slide? This one or the previous one?
The previous one with the antipsychotics, because I think it really, as you said, it's a big category here and stuff. And kind of what I'm hearing from clinicians, and I think you named the first generation, still hearing like that, like haloperidol pop up constantly.
Wow.
Okay. Yeah, so like I'm still seeing yeah and I guess that was because I kind of have 2 questions, so maybe I'll name both and stuff, and like my background is public mental health, so again, that awareness of like what you're saying, talking about that shift in things, and that's something I'm trying to adjust to and support clinicians with in this space. So there's still, I think as well, because like you named, we're actually seeing a much more complex participant range in this like roles than I probably anticipated. We see, like as you said, the intellectual disability, but we're seeing a lot of older participants, so that's why. So we're seeing people in their 60s, some in their 70s, even though they're kind of bridging that NDIS age limit and stuff like that. But so the first generations are still like popping up that I hear about. So I guess like, what do you encourage us to do, like in roles in terms of, that kind of area? But something else I think that's so important that you named is ultimately all these side effects around everything. So the type 2 diabetes, the weight gain, all this other stuff. So I think what a lot of clinicians bring up to me is all the extra medication someone's on, which are ultimately these diagnoses, but do they have diabetes? Do they have this? And, I did have a curiosity about one specific medication that comes up a lot, which is sodium valproate. So from my history, that was always in mental health.
Yes.
And then I just kind of, I would just love to hear some perspective on that. So first one around first generation stuff, and then that side effect and sodium valproate.
Okay, so there's 3. I think the 2 points to this question, just to talk a bit about why we still seeing people on FGAs, and secondly, can I speak a bit to sodium valproate? Okay. Second answer first. Sodium valproate is an anticonvulsant medication.
Yep.
was used as it suggests for epilepsy. In the mid to late 90s, it was found that anticonvulsant medications such as sodium valproate, carbamazepine, and lamotrigine were quite effective for bipolar disorder, particularly type 2 bipolar disorder, not the classic type 1, but where lithium is the treatment of choice. So sodium valproate is usually used to manage bipolar disorder. I have seen it used in some circumstances to augment antidepressant medication efficacy. It can be used, but it's really not that convincing as a kind of, I suppose, anti-aggression medication. I yet to see that really work. Sodium valproate's usually pretty well tolerated. Some people can get into a little bit of trouble with liver disturbance. In fact, at one point, sodium valproate was actually banned in the United States initially because of its hepatotoxicity, which we haven't seen that much of. The main side effect, actually, particularly for women, is it can make polycystic ovary syndrome much worse, and it can actually cause some polycystic, look, all women with ovaries have cysts on their ovaries, but sometimes the valproate can actually cause those cysts to start pumping out androgens and cause the syndrome of polycystic ovary. So we need to just be aware of that. Sodium valproate is not a medication that keeps me awake at night, but it's certainly one to be aware of. Now, with the first generation antipsychotics, I would imagine because of the fact that contrary to the intentions of the NDIA and its architects, the states vacated their responsibilities to people with severe and persistent mental illness and basically dumped everybody in what Mr. Shorten refers to consistently as the only lifeboat in the ocean. So we are tasked with the care of people with severe and persistent mental illness in the NDIS because the states have just basically, refused to do the washing up for the last decade. So you will probably be seeing a lot of people with chronic and persistent mental illness like schizophrenia or bipolar, or in some cases some of the more severe personality disorders, who are on these drugs because they've been on these drugs for many, many years. That's probably has some explanatory powers to what you're seeing there, Ryan. So that's the first thing. Now, in my, I've been doing this for for 35 years, and what I've found is that you'll see a patient with a long-term psychiatric problem on a really weird combination of stuff, and you think, oh, that's not right, and you go in and change them, and you and the patient both regret that decision within about a month. Within about a week of you getting all heroic, they're in hospital because you've made them sick for the best of intentions. So I think that kind of, if you've got someone on a lot of different stuff, fools rush in, I think, with this one. The point you make, though, is important, that if it probably needs to be as a point of regular reflection, who's prescribing this, why are they prescribing it, what are we taking, what are we using, what are we treating? Certainly with the first generation antipsychotics, my experience has been, somebody goes in and say, okay, someone's taking haloperidol, which is, if they have to, and they're on, 10 milligrams of haloperidol. They've been on that for 30 years. And someone says, oh, you're looking a bit stiff or wooden. I'm going to reduce the dose to 7.5 milligrams. And as I say, within a week, they're in hospital psychotic. So in some circumstances, the difference between 10 milligrams and 7.5 milligrams is all the difference in the world. And so the caveat with these is, I think any changes to medication need to be, really strongly indicated, and they need to be extremely carefully done. Right.
Yeah. Thank you.
Coming back, say we see people who are on, like, as I say, an older person who's been on a benzodiazepine for 20 years for sleep. You stop that quickly, you'll know, that'll create problems as well. But so I don't want to sort of say don't touch it, but I'm saying is I think that we just need to be quite deliberate, because a lot of these long-term things, and I think it makes sense if you kind of are doing things to the brain and inhibiting certain activities, when you then stop that, you'll get a rebound. So you get, there's a phenomenon called supersensitivity psychosis, where basically if you block everyone's D2 receptors, chronically, and then you stop the blockade, the brain will make more D2 receptors. If you block 100 D2 receptors, the brain will make another 100. When you then remove the antipsychotic, you've got 200 D2 receptors, overactive, and that's why you get the supersensitivity psychosis. So I think the same phenomenon is seen in antidepressants and the like. So these medications will bite you and bite the client on the bum if you get too clever too quickly with them. So I think a lot of that has to be just done in that way. So does that kind of address those?
Yes, that does. Thank you. I know
Okay.
it's this kind of broad thing, but I really appreciated that input and
Okay.
insight.
No problem. All right. Now, I think there was a
Michael,
question.
we got one more question from Cass before we
Yes,
move
absolutely.
into our last slide.
Okay. Go ahead.
Hi, are you able to hear me?
Yes.
Go for it. Cass.
I just had a question just off the back of that. So say for someone that does have a diagnosis of a more like complex chronic mental health condition like schizophrenia or bipolar, how common is it for them to be able to taper off their medication, or is it generally that these medications are sort of lifelong prescriptions?
Yeah. Probably the latter. And the reason is that, just as I was sort of saying earlier with Brian, that a lot of the damage, say with the newer ones, a lot of the damage is done early. So somebody takes Zyprexa and puts on 15 kilos and becomes insulin resistant and hypertensive. You could stop the Zyprexa and the weight won't disappear overnight, but the madness will come back pretty quickly. So that's really the challenge with that. So and there's a lot of work being done by a lot of people over many years trying to work out how to mitigate this iatrogenic harm from these drugs, and there's really been no compelling answer. In some circumstances, people get put on metformin when they get put on the antipsychotic medication. I don't think it's been that impressive, the data. You've had some, better funded services trying to have EPs, getting people more physically active, but exercise is fantastic for health and it's magnificent for preventing illness and prolonging life, but it is not that good at getting weight off. You can't outrun a shit diet. And unfortunately, eating well, that is, eating your 5 serves of fruit and vegetables is expensive and very hard to do on a DSP. So we have a lot of those challenges with that. So a lot of the sort of trying to prevent these things is a noble but has been ultimately fruitless, not futile, but certainly very challenging task. So to come back to the question, by the time I think we're sort of providing the care for these folks, they've been on this stuff for quite a bit of time. The indications to stop them is potentially, compelling, but it needs to be balanced against the real risk you run of making someone unwell by stopping their meds. So this is why there's that really enormous caveat over making changes for the sake of making changes. So I think, does that sort of answer your question on that one?
Great, that's great, because I definitely have a lot of clients sort of, I guess, pose those questions like, I'm experiencing all of these side effects. Can I come off this medication? Obviously, that's not within my scope to address, but just sort of wondering, like if it is something that's possible in the future. But as you said, you need to weigh up the side effects. Yeah, well, I mean, side effects, yes, absolutely. I mean, the side effects are, if you have to take something, if you've got to take it long term, yes, you have to do it. But it's obviously the balance between that and becoming unwell again. Really, first generation antipsychotics, second generation antipsychotics, it really for some people is, do I want to be shot or stabbed? They're both dreadful classes of drugs, but for a lot of people, that is the difference between being well and being unwell. So it's got to be that kind of the balancing act that we do. Certainly, with the newer ones, the metabolic stuff, the solution is obviously try not to get there in the first place, but if you do, it's going to have to be
us being more creative or lateral thinking in nutrition and lifestyle interventions. I'm not poo-pooing exercise intervention, not at all. I'm a huge fan of it, and as I said, I've made my business to try and disseminate it through the group. But I think we're not going to get 15 kilos off with the kind of exercise you're going to be able to get people to do. If you're going to start running half marathons, good luck to you. But most folks aren't able to do that. So I think we just have to almost bake in as a routine thing. What can I do to help with the metabolic health of this person? Kylie, I think is the question.
Hi. I
Morning.
just wanted to ask more about the melatonin because
Yeah.
I know it is safe to use, but I tend to have a lot of parents that run and use melatonin as a straight up method to support their kids with sleeping instead of trying to try other routines and sleep hygiene and stuff like that. Do we know if there is long-term effects on that? How can we really address that sort of thing with parents using melatonin instead of implementing other stuff?
I don't think melatonin's been shown to have too many problems. I think it's a reasonably safe intervention. It doesn't concern me the way, say, benzodiazepine or clonidine would. You can. It depends also on the melatonin. I mean, you've got the sort of reasonably decaffeinated stuff you buy from the pharmacy as against the sort of weapons grade melatonin prescribed. But I'm not aware, and I don't think there's been any significant long-term problems with that. But I think it is a useful adjunct to other things. But in some circumstances, it can really make a huge difference to quality of life. So I think it's not a drug that I would worry excessively about over a medium-term use.
What if the parents have been using it over long-term use? I had one parent who's been using it for 2 years. So, would that still be? Would I be concerned with that, or?
No, I don't think so. No, certainly not compared to some of the other ones we've been talking about this morning.
Not cool. Okay. Yeah, cool.
Yeah.
Thank you.
Sarah.
Michael,
yeah.
I'm just conscious before we go to Sarah, we've got 5 minutes left.
Okay. All right. I will try and be curt.
If you wanted to.
Brief. All right, Sarah.
This will hopefully be quick because it's piggybacking off the last one. But what about Phenergan?
Yeah, Phenergan is a antihistamine medication, promethazine. Has a huge hangover. It often, people aren't much good before lunchtime after a dose of Phenergan. It can, over time, cause problems with paradoxical responses where people become agitated rather than sedated. It also has other side effects. It can also cause some cognitive impairment and the like. So I think Phenergan should be something that is used intermittently but not routinely.
Okay, yeah, it's a PRN for some client participants I have for their child, and they use it almost every night. So I think that'll be something that
I'd be maybe looking at alternatives. But yeah, Phenergan can have a little bit of a problem over the longer term. Just I think with some of the other side effects from it.
Thank you.
And I think it also stops working after a while too. So. And was there one other question? I think. I've only just stopped coughing, so I can talk now. So.
Can I ask a more PBS specific question, if that's okay? I guess I'm interested to know, as a psychiatrist, what would you be looking at? What information would be important for you to know, for you to then think about fading out a restrictive medication in the future? And how can PBS Pracs best, I guess, present that information or the care team to you?
So what would be the reason for me to want to stop something? I would always be looking to try and minimise pharmacological treatment, as Julian Troller's sort of comments earlier in the talk highlight. We want to try and get away with the minimum we can. I think I'm vigilant for side effects and tolerability problems. If people just finding the quality of life's impacted by it, then obviously that's a strong argument for it. All of this is always going to be that risk balance. So, does the price of admission of taking this thing actually give the person the quality of life improvements or the symptomatic relief that they need for that quality of life? Is that equations still sort of favour using it. So I think I can't have a sort of hard and fast rules, but I would always blah, blah, blah. But I would obviously try and minimise exposure to antipsychotic medications at the get-go. Most folks, I think, come to us on long-term treatment anyway, which is obviously a challenge. And that's, I think, as I said earlier, the circumstances where we don't want to just rush in and do things for the sake of it. But I'm just always, I think, thinking about does the risk-benefit equation still favour doing something? And that would be the kind of rule of thumb for any of these interventions that we're talking about. So, you know, for the earlier question about melatonin, if the young person is sleeping, everyone's happy with it, there really is no reason to stop it. Phenergan, though, there's an alternative. If this young person's not really much good until 10 or 11 in the morning and they're starting to show some learning difficulties, what have you, then we need to rethink what we're doing. All right. Chris, I think we probably...
Do you want to run through your take-home slide?
Yes, very quickly. Okay. So the take-home slide is, firstly, around 30% of NDIS participants, particularly those with intellectual disability, have a comorbid mental health problem. So, yeah, there is reasons for these drugs to be used. We seem to understand about 45% of people with intellectual disabilities who are NDIS participants are prescribed psychotropic, so it's extremely common, and that's obviously been everyone's experience. We have to remind ourselves these are restricted practices, and we need to have the appropriate safeguards, both the ethical and clinical kind of guardrails that we've got for that. We need to be constantly talking, you know, have to balance, we need to be constantly vigilant about side effects rather than necessarily talking about them all the time, because in some circumstances people will, you know, if you say someone's going to have a side effect, then they'll have it. But I think we have to be aware that sometimes where there are communication challenges, the participant may have difficulty communicating some side effects. And also, you know, particularly if it's sexual side effects from an SSRI medication, there may also be other barriers to that. So I think we always have to be mindful of their potential side effects causing a problem for this particular person, and, you know, how do we raise this with the prescribing clinician? We need to always be aware, I think, just if someone's taking these medications, just be mindful in our day-to-day practices as to what are the adverse effects. You know, if you're noticing people starting to get, you know, putting more and more weight on after starting a medication, how to communicate that back to the prescriber and how do we try and mitigate that. And as I kept saying, I think foregrounding physical health concerns, particularly metabolic health, is the big take-home for this talk today. All right.
Thank you, Michael. There are other points in the chat, but I'm sure we can chat about that and come back with some further.
I'm happy to hang back. I'm happy to hang back if you want to do that. So.
Wonderful. I'll take this opportunity while most people are online. So thank you so much, Michael, for your time today. I think based on some of obviously the comments that are coming through the chat, this has been highly valuable for the team and something that I think from the sound of it, it's addressed a lot of the points that the team have had in this particular area, and having someone of your expertise come in here and sort of add some further knowledge in this area has been highly valuable. So thank you very much for your time. And I'm really confident the team's got a lot out of this.
Yeah. I'd also just point out, as my position as chief psych for the group, I'm always happy to have approaches about these sorts of questions. That's my job is across the whole group. It's not just the medical legal stuff. So doors always open.
You open that door, it might get flooded now, Michael. So
no, that's my job. That's what we did. What I signed up for.
Brilliant. Well, thank you. If anyone's got any additional questions, I think Michael said he's happy to hang on the line. So I've got a couple in the chat that I might pose to Michael. So feel free for those that've got the capacity to hang on the line. Otherwise, thank you so much for your attendance, everybody. And this session, Michael has allowed this session to be recorded. So I'll share this with Ellie and make sure this is available for the entire PBS team, particularly some of our colleagues who may not have been able to get here today.
No dramas. All right. So did anyone actually have any other queries?
Yeah, I just wanted to ask. Hi, Michael.
Hey.
I wanted to ask about back to the melatonin topic, because it's quite it's becoming quite common because people are realizing sleep issues kind of affect a lot of your life day to day. And I study naturopathy, so it's a big realm in our industry as well. With obviously a lot of kids are prescribed medication, prescription and over the counter. But before, you know, it gets to that stage, as behavior support practitioners, because I am one, is it within our capacity to suggest, like, for example, devices stopped now? And obviously this comes into the realm of behaviors. So this is why I'm asking.
Sure.
Say we can recommend to the parents or carers like an hour and a half before bed to limit device usage, dim the lights up to 50% or less than 50% to kind of expose the body to darkness and get the body ready for bed. That sort of stuff. And like even introducing certain foods such as like pistachios, walnuts, almonds, they're high in melatonin naturally. They want to consume them towards the end of bed so that your body can naturally kind of have an elevated melatonin level already. Is that something that we could or should recommend or suggest to parents, caregivers?
Yeah, no, I think you've almost answered your own question there. I think that you know, those elements of sleep hygiene are really important. I would sort of say, just given our culture, if you say there is a pill, people will just say, yeah, give me the pill.
The easy fix. They don't want to adopt.
Every aspect of medicine, apart from the pills I give out, everyone kind of, if there's a pill answer, people will sort of go to that, and that's just, you know, we have grown up with technological solutions to life's problems. So I think if you sort of, the way I would do this is sort of, if you want to kind of foreground the interventions that you've talked about, I'd be sort of talking about melatonin as a kind of, if it really, really, really isn't working, then we could do this maybe a couple of times a week. Because I think if you just say, look, it's safe and it's reasonably effective, then that's what they're going to be doing each night. No, not the worst thing in the world, but I do think, as you say, some of those sleep hygiene interventions, particularly limiting, you know, the amount of device use, that kind of easing into the night's sleep. Interesting. I actually sort of always regarded sort of eating more than 2 hours before bed as being likely problematic. So it's interesting that you mentioned that those melatonin-rich foods might be helpful.
They say 30 an hour before bed, 30 minutes an hour, like just snacking on maybe 20 nuts or something. But yeah, like it. Yeah, that's true.
But I think actually I've done a lot of reading about the sort of benefits of heat bathing, particularly sauna bathing. Not everyone has sauna, obviously, but if a kid really is unsettled, sometimes just a soak in a warm bath, actually just having a bit of a heat